All right, so thank you for that introduction. We're just gonna run through some disclosures, and James has a much more established disclosure list than a slide than mine. So I'm gonna let you go ahead, James.
Sorry, just land acknowledgement that I'm on the traditional unceded territory of the Algonquin Anishinaabe people, and I honor them. Former co-chair of Physicians Advisory Committee of Dying with Dignity Canada. And so naturally, I'm currently employed by a faith-based institution, go figure. I've received money from companies that have nothing to do with medical assistance in dying and consulting fees for developing communication and education material. And I was an expert witness in 2 cases relevant to MAiD in Canada.
And I have no major disclosures other than I'm very new to this country, very new to this city, and so I'm learning a lot about medical aid in dying or medical assistance in dying, and so I'm grateful to be here. Okay, so we have, we will fill part of this time and hopefully have some time for discussion as well. We have an agenda that includes discussion about fundamental tension in the relationship between palliative care, medical assistance in dying, about what triggers a medical, well, I'll just call it MAiD from now on, request in people followed by palliative care. The relative role of palliative sedation and medical aid in dying and people approaching the end of life, and then we want to sort of just tackle this question about whether or not MAiD is a symptom of palliative care deficiency, as has sometimes been viewed. Okay, so let's talk about this sort of fundamental tension, and I want to start off by telling you sort of 2 tales in a city just from my brief experience here in Canada. And so this is somewhat of an outsider's perspective, I guess, on this, having come from a place where discussions about this are really only theoretical in the state of Massachusetts. So the first is a story about a man in hospice. And this is a story I was told by one of my colleagues who runs a maison soins palliative. And it was about a story of a man who was who came to the hospice in a late stage of advanced cancer and really was doing quite poorly and was expected to live for a matter of weeks. And this was a person who, as many of us has experienced in the past, did actually really well with the hospice care that he received. And with daily care and good symptom management, he actually lived for for several months, for let's say 4 or 5 months, to the point that there was a question about whether or not he could actually stay in the hospice, because these are, of course, places with limited resources. And so it was sort of brought up that there may need to be a change because he was actually doing so well. With good supportive care. And so the discussion was about whether or not he would go to a nursing home, CHLD, here in Quebec. And it was at that point that the man said to the palliative care physician who was caring for him, I really don't want to go to one of these places. I don't know anybody there. I don't know what it's going to be like. And so for this reason, I would like to have medical aid in dying, medical assistance in dying. Okay, so I'll leave that there. And I'll tell you another story. So a woman in the emergency room, this is something I actually experienced firsthand. And this is the story of a 75-year-old woman with a very actively involved family with an advanced cancer, who had decided in consultation with her doctors, including her palliative care physician, that medical aid in dying was something she was really interested in. She talked a lot about it with her family, and that was sort of the plan. Okay, but because she was doing, she wasn't quite there yet. No plan had been made for that, so to speak. And so anyway, then as sometimes happens with people with advanced cancer, she had some sort of event in her care that necessitated admission to the hospital, and she came into the emergency room in a lot of distress and a lot of pain, potentially for possibly related to a bowel obstruction and rupture. And it was when we saw her in the emergency room, there was a tremendous amount of distress in her and actually more in her family, because she had talked with them about medical assistance in dying and the desire to have that. The fact that it couldn't be given immediately in the hospital was a source of tremendous distress for this family. And in fact, the inability to get MAiD in very short order was probably the greatest source of distress, because the patient herself wasn't terribly uncomfortable lying in the bed, but the plan for this and our inability to realize it was really, I think, one of the things that drove the most distress in the patient and the family at the end of life. Okay, So those are just two stories that highlight a little bit about what I think are at the core of some of the fundamental tensions that are here. Okay, so philosophically speaking, palliative care has this sort of foundational belief in the potential for healing through the course of serious illness and up to and beyond death. And for me, this is like the radical proposition of palliative care. Even though people have talked about, people like Osler and Peabody have really talked about, whole person care and healing as sort of being at the center of medical care, the idea that it can happen in the setting of the sort of degradation of the body that comprises serious illness is I think, radical in the history of medicine. Cicely Saunders in the UK at St. Christopher's Hospice, who founded St. Christopher's Hospice, said, "You matter and you matter until the end." And along with that goes this idea that death is a natural process and should not necessarily be hastened. And really, while many people associate palliative care with end of life and dying, palliative care clinicians would tell you that really our focus is on living as well as possible, in spite of serious illness and on up until the end of life. And some people have even proposed that palliative care is an antidote to euthanasia. Okay, on the other side is medical aid in dying, or medical assistance in dying, which is kind of a, while maybe not explicitly stated, is is based on the idea that you matter until you feel you don't matter, and then you can pursue death. And it is an end of life option. I would say it doesn't necessarily require palliative care, and it, rather than being focused on living, it's really kind of focused on dying. And that's not a critique. I think that's just literal. And it is in fact literally euthanasia, which I spelled incorrectly. I apologize. Okay, but there are things that are shared between these two constructs of palliative care and medical aid in dying. And so really, like, at the core of it is this idea of addressing suffering, which is, for the last 40 years has been much more central to the practice of medicine. And I'll call attention to the fact that RQSPAL wrote his seminal piece in the New England Journal in 1982, so 40 exactly. This idea of a good death, which is comprised of sort of control over dying circumstances, the idea about preparation, about autonomy and a choice over what your own decisions, dignity, in fact, and then acceptance of death. And I think has been pointed out by others. There may be ways in which people in palliative care and those who are, opponents, let's say opponents and proponents of medical aid in dying, whether they're in palliative care or not, view some of these things differently. And that's okay. Okay, so just to say, though, that this is a fundamental tension that is not going away, right? So this is actually from a paper that was shared by one of the folks on this call that really highlighted the ways in which the jurisdictions in which medical assistance in dying is available, continues to grow. And this is just sort of keeping track of this over time. And this is really this is not something that can sort of be put back in the bottle at this point, even if that was desired. And I think that, one of the things that's interesting that they talk about in this paper is, the sort of camps in which people fall in terms of the relationship between palliative care and medical assistance in dying. So there are those who are sort of flat out opposed, remain opposed, and ways in which that's reflected through complete separation of services. So there's, for instance, a palliative care service and a medical assistance in dying service, and they don't interact, and they, or at least certainly don't coordinate, but they're separate. There are certainly countries and service hospital systems or systems in which there's sort of an ambivalent relationship in which they sort of coexist together. And then there's this sort of more cooperative approach that some have, where palliative care clinicians are sort of more actively involved in the in decisions about MAiD and even in the provision of MAiD. And those reflect sort of more coordination and collaboration. One of the things I've been struck by, again, in coming here as an outsider, is it seems to be there's a relationship potentially with age a little bit in generation, or if not age, at least like length of time in practice. Because one of the things I experienced in coming here and having conversations as a palliative care physician and leader in this community about medical assistance in dying is that, there was a lot of political, I'm not telling you anything you don't know about, a lot of political opposition to medical assistance in dying. Some people on this call, like James, were on the very forefront of this. And now, what I see among young clinicians who have trained after the matter was sort of settled, is that there's very little resistance. There's much more of a cooperative and participatory attitude towards medical assistance in dying, and not some of the, I think it would be pejorative to say baggage, but just what is brought with people forward into this time, from a time when there was a lot of vehement resistance to it. And so, I think one of the questions for myself, for all of us, but certainly something that I'm thinking a lot about, is how do we resolve these sort of fundamental tensions? Are they really fundamental, or is there a pathway that can sort of lead us to a place where we work really, where we work closely together within a legal framework that is really already defined? Okay, so I hope that gives some sort of introduction to what I see as the fundamental tensions of this, and I'm going to pass it over to James. And James, you just tell me when you want me to advance the slides.
Thanks, Justin. Please. So the three sections I was going to cover today, number one was just quickly to touch on what triggers a MAiD request, and the three things I'm going to cover are, each one of them probably could be a very long talk, so I'm going to do very high-level discussion. I think there'll be some questions and discussion afterwards, so I'll do what I can. Again, I think it's been covered already, but I think what generally triggers a MAiD request among all people, particularly among people with who are followed by palliative care, is not physical symptoms, anxiety, or depression. That it really relates to existential distress. However one might define that, I think there are a lot of working definitions of existential distress. I'm not going to get into them here, but really just explain that it's less about physical symptoms, anxiety, or depression, which are the major things that we tend to address in palliative care. So then the question, of course, obviously comes up: is palliative care, or what can palliative care, or anyone else for that matter, do for this type of distress? And the core lessons from the literature is that it is not extremely well studied. That what has been studied, there's a lot of issues with the literature, and that not many things have shown real benefit for this type of distress. Can you go to the next slide, Justin? Speaking of age, this is like a 1980s talk where I have the next slide, please. So I think we already saw this graph from the Health Canada presentation earlier, but again, like the number one and two things that you see in Canada: loss of ability to engage in meaningful life activities, loss of ability to perform activities of daily living. Where physical symptoms and psychological symptoms come into it are much further down, and actually relate as much to concern that they might happen rather more than that they are actually currently happening. Next slide. This is similar data from Oregon. I'm sorry, it's a very, very bad PDF projection, but really showing that the reasons for requesting physician-assisted suicide in Oregon are usually not physical symptoms, but anticipated loss of control and reduced quality of life. The red line, the red arrow actually indicates the highest ranking physical symptom, pain at the time of request, which was only a 2 out of 5 on the median score. Next slide. So if we're going to focus on sort of distress and broadly defined distress in palliative care settings, it's important to understand how limited the literature is really around this. There was a Cochrane systematic review of anxiolytic use in palliative care for anxiety in palliative care settings, and actually not one study even met inclusion criteria for the study, which is always a good sign. In terms of a systematic review of antidepressants in palliative care, their conclusion was that there were very heterogeneous results with more negative than positive results. There was nothing at all listed for existential distress under pharmacologic options, which is obviously very concerning if that's the main thing that we're talking about here in MAiD. I think anyone who's talked about using these medications in a palliative context, a number of the considerations that come up are frequently that there is, number one, a delay in treatment effect, right? So people aren't expecting immediate response, and if you're talking about a relatively short time period, that obviously limits people's enthusiasm to take on the medication. Side effects and drug interactions also can be quite common, particularly as people are getting increasingly frail and approaching the end of life, and with other medications that they're on, that creates some concern about starting these medications. Next slide, Justin. And then in terms of non-pharmacologic or psychological interventions, there actually is a lot more published, but unfortunately not a lot better news in the results. So this systematic review and meta-analysis of RCTs looking at various different types of therapy, and I do acknowledge that this is a bit of a smorgasbord of meaning-centered dignity therapies and hope therapies, and they did not include spiritual or religious therapies. So they were all sort of combined. They were not combined all together in a main study, but they were compared individually, and different aspects of the therapy were studied. But the bottom line is that they did find that there was a significant improvement in existential well-being, quality of life, hope, and self-efficacy immediately post-treatment. However, the standard mean difference, which is a sort of measure of the magnitude of effect, was not exactly impressive, right? So when you think of standard mean difference, those who are not sort of familiar with the concept, usually numbers like 0.8 would be considered a large effect size, 0.5 would be moderate, 0.2 would be small, and anything less than 0.1 would be non-significant. So a 0.12 to 0.15 is in between non-significant and small. So hardly something to really hang your hat on, I would think, if you're going to try to sell it to somebody. Hope scores improved at 6 months, but nothing beyond 6 months. There was no measured effect of these interventions on anxiety or depression. And there were a number of moderator effects that are listed here. And the authors of the study highlighted a number of concerns about heterogeneity and bias, especially publication bias, which would suggest, if anything, that even this very modest effect size may have been an overestimate of the true effect size. Next slide, please. The third thing that we're going to talk about today is just a little bit about palliative sedation and its position vis-a-vis MAiD. I think many people, certainly in the early days of MAiD legalization in Canada, people would often mention palliative sedation alongside MAiD as, potentially two options for the same type of situation. I thought it would be worthwhile just to quickly touch on the theoretical distinction, but then the clinical reality, and then talk in practice about when we might opt for one as opposed to the other. Next slide. So, and again, this itself could be a very long discussion. I'm just going to go at sort of high level here and say that when we compare the two in terms of intent, in both cases, really the intent is to relieve suffering of the individual. But the means by which you do that in palliative sedation, a reduction of consciousness versus directly causing the death of the patient as you do in assisted death. Palliative sedation may have the unintended potential consequence of the patient dying sooner, but that's not the primary intent or the primary means by which you achieve the endpoint. Generally speaking, palliative sedation guidelines where they're published suggest that this should only be used in patients with a short prognosis, because if you obviously do it open-ended for a very long time, it will affect their lifespan, but for a short time, it is not felt to. So generally speaking, you're looking at different time courses for when you would actually use this. Generally speaking, palliative sedation guidelines focus heavily on use in physical symptoms and for addressing physical symptoms, whereas assisted death, as we've seen, is much more about existential distress rather than physical symptoms. Some people talk about a prolonged or proportional palliative sedation approach and a short procedure and assisted death, and then the distinction, of course, between causing death and allowing death. Next slide. People pay a lot of attention to how the numbers evolve over time when you legalize medical assistance in dying, but you have to remember that palliative care is hardly standing still while all of this is going on as well. So looking at the data over sort of 15 years, starting just before legalization, this is data from Flanders, you'll see that with the legalization of medical assistance in dying in 2001, the physician-assisted death numbers actually fell for some years before recovering to be higher than they were at baseline. But there was a much more substantial increase in the use of practices that we would consider to be palliative care in North America and elsewhere. So quite a substantial increase. And a large proportion of that, as you can see in the fourth line down, is continuous deep sedation. So sedation going from essentially nil to 14-15%, where physician-assisted death climbed only by about 1.5% or 2%. Next slide. We have a little bit of data on this from Canada because Quebec also, as part of Bill 52, collects data on palliative sedation use. And you can see that obviously the growth in the blue bars, which is MAiD, was more substantial than the growth of palliative sedation. But palliative sedation is still being used quite commonly and in an increasing degree in Quebec up until, I don't have data beyond 2018. If anyone has it, I'd love to see it because I'd love to know where it's going. Next slide. Now, although I've given you sort of a slide showing that the very clear distinction between the two, in practice, it's not actually always all that clear. right? So a lot of studies have highlighted that there can be very big confusion about the intent, and that in Netherlands, nurses, 3/4 of nurses in Netherlands feel that palliative sedation is at least partially intended to cause death. Many nurses in nursing homes feel that sedation is intended to cause shortening of life to a certain degree. Interestingly, many cases, some euthanasia cases, are actually labeled as palliative sedation. I'll show you the data behind that in a second. And it's clear from a number of qualitative studies that my favorite line is that intent in palliative sedation is multi-layered, ambiguous, subjective, and often contradictory. So I think that's an important concept to bring home, right? That it's actually not as cut and dried as it is in the textbook in practice. And again, to what Lauer's life-ending acts without explicit request, which are these sort of non-voluntary euthanasia cases in Flanders. Next slide, I'll show you that.
Just very quickly to interject, James, having been here only in practice only a couple months, I think this resonates a significant amount with me about the confusion of intent, and what I've heard in a very short time being here from various parties, just to say.
Yeah. I think that's an important point. So these life-ending acts without explicit request. So remember, in Flanders, when they collect data on this, they send surveys post-death to physicians. They're anonymous, so they can fill out, even if they broke the law, they can write what they did without fear of consequence. And this is the standard practice they've been using for decades. And they're asked, did you perform an act that ended life? Did this person make an explicit request themselves for it or not? And there were a number of cases collected where people checked off that they performed an act that ended life, but the person did not give explicit request. And these 66 cases caused a lot of anxiety among, in the published literature. But when you look at what did they actually classify their own treatment as, they said, 2/3 of the time, they said it was palliative sedation. And if you look at the next slide, and you compare the medications that they used. So in the middle, we have the medications used in these life-ending acts without explicit request. On the left side, you see intensified alleviation of pain and other symptoms. So what we would consider palliative care, or what we might call palliative care. And then on the right, the medications used in euthanasia and assisted suicide. And what you see is that the medications used in these Lauer cases was almost identical to the medications, or were almost identical in description of the medications used in palliative care, and very different than the medications used in euthanasia. So again, the line between the two can be a little bit fuzzy and gray, even if it's not in the textbook. Next slide. I think in practice, and Justin gave a great example of a case where somebody sort of shows up and it's like, code MAiD, I want MAiD like right now. And that's just not realistic in many cases. The process involved, you know that this person has got maybe hours or short days to live. They're in a lot of distress. And the idea that you're gonna try to treat those symptoms, keep that person competent for 2 assessments and then get MAiD is just not realistic. And in situations like that, you'd be very obvious and say, look, I just don't think this is gonna happen. Palliative sedation, I can do that right now. And I can do it now. I can do it with your consent. I can do it with consent of a family member. It's a much simpler procedure. And even in Quebec, it's a lot less paperwork. So, there are certainly situations where I think palliative sedation is a very reasonable and in fact, probably desirable alternative to MAiD that we need to acknowledge. Next slide. And if I haven't ruffled enough feathers now, I'm going to do this hopefully in this section where we talk a bit about the notion of MAiD being the result of so-called palliative care deficiency. I think in the 80s and 90s, it was very reasonable to believe and be concerned that MAiD would be essentially the result of people not having reasonable access to medical to palliative care. But I think with the benefit now of many decades of data, multiple decades of data in different jurisdictions, I think it's really hard to sustain this narrative, both in terms of data we get from individual cases, but also population level data, which I'll show you, populations that are known to get more and better palliative care that also seem to get more MAiD. Regions with good palliative care are the regions that legalize MAiD and have higher support for MAiD. Availability of opioids, all the things that people were concerned about, except that they all tilt the other way from the way that we would have feared. And I think it's also important just to recognize that as we're talking about palliative care as a potential alternative or a cure for MAiD, so to speak, we have to also be a bit modest about what we're expecting palliative care to be able to do. And I'll show you just one slide on that. Next slide, just. So again, Health Canada sort of showed this already, showing fairly high proportion of people who were receiving palliative care or disability support services among those who received MAiD. I'm going to talk about this more in a second, but if you go to the next slide, We also found in Ontario, when we did a study using records kept by the the Office of the Chief Coroner of Ontario and ICES, that very, very high level of palliative care involvement even before MAiD was requested, and then following and during the MAiD assessment, more to the point that we were getting almost identical numbers to the Health Canada reports. Next slide. Questions got raised about the study that we did, and people were sort of questioning whether there were biased assessors. Certainly, the Health Canada report was based on self-reporting, and people, asked, essentially the providers were being asked, was palliative care offered, was palliative care available, etc. More details are being sought on that now, but in the early reports, they were asked fairly straightforward. But in Ontario, that was absolutely not the data we relied upon. In fact, every single case, as was pointed out, every single MAiD case in Ontario is reviewed by the Office of the Chief Coroner of Ontario, by experienced trained nurse investigators. It is not based on billing data. Again, you may agree, you may disagree with their assessments, but it's hard to imagine how you could get a more trained and less biased person than these nurse investigators to decide. And they're getting almost exactly the same numbers that the Health Canada people, the self-reporting is. So I would say that I think these are reasonable data to work from. But if we want to ask questions then potentially about what was the quality of the palliative care or access, well, that's another level of question that we can get into. The challenge, of course, is that there is no validated measure of palliative care quality or access, right? So any argument based on palliative care quality or access is essentially a hand-waving argument. I can certainly accept that, it may be possible that many of the people getting MAiD were not getting the best palliative care. Maybe they got the palliative care later on. I'll show you data that suggests the contrary. But among those who get later, was it possible that those who got good and early palliative care would get lower incidence of MAiD versus those who got poor or later palliative care got a higher incidence of MAiD? That's possible. But following on that sort of dose response curve, you would expect those that got no palliative care should probably have the highest incidence of MAiD, and you don't see that. So it doesn't make sense that the middle group would have the highest incidence of MAiD if this was driven in any way by the quality, availability, or indeed any involvement of palliative care. Palliative care availability, I want to be super clear, is a problem in Canada. It is something we need to improve, but it's not an issue that's driving MAiD. Next slide, please. Interestingly also, so looking at who gets MAiD, right? So the type of illness seems to be probably one of the most important factors in who does or does not get MAiD. So this is from our Ontario study looking at databases and who got MAiD and what illnesses they had underlying it. And you can see that essentially MAiD cases were almost 10%. In cancer, about almost 10% of deaths from cancer were MAiD deaths during the study period. And then you compare it to other non-cancer illnesses, it's much, much lower, right? So you're looking at sort of 2, 3, 1% or less of deaths in many of these other conditions. And if you compare, for example, cancer to respiratory illness, you'll see that cancer cases, somebody with cancer is about 3 times as likely to die from MAiD as somebody with an end-stage respiratory illness. Next slide. If you look at income and who's getting MAiD, you'll see that certainly the poorest quintile of Ontarians are about 39% less likely to get MAiD than the richest quintile. And that trend was seen across every single subgroup, whether it was age, sex, what illness they had, malignancy or non-malignancy, how many times they came to emergency room, basically everybody except for urban versus rural, but it was a very small number of rural in that case. Next slide. So knowing that that's who gets MAiD, look at who gets palliative care, right? And just focusing in on a condition, and I think the comparator of lung cancer versus end-stage lung disease like COPD is a very apt one, because we have good data to suggest that the palliative needs of patients with COPD are the same or possibly worse than those dying of lung cancer, right? That's, I think, pretty well known. But you'll see, again, that the patients with lung cancer are substantially more likely to get MAiD, but they're also substantially more likely to get palliative care. Compared lung cancer only is about 2.5 times the odds of getting a physician home visit or a palliative physician home visit, and about 4 times the odds of getting palliative home care of any kind. And again, the same income trend seen across all the various income quintiles, right? So again, people who are getting, if you were expecting MAiD requests and provisions to be driven by unmet palliative needs, then you really should not see this trend. You should see exactly the opposite, right? That the people with end-stage lung disease should get substantially more MAiD than the people with lung cancer, but they don't. Next slide. And again, just more sort of showing this, right? When you look at the duration of palliative care, the people dying in the sort of terminal illness trajectory, right? The first column here versus those with organ failure, the second column. And I'm using only Ontario data, so we're really comparing in the same jurisdiction here. You'll see that, you know, people dying of cancer are in this, by this definition and using the coding system that they used here, about twice as likely to get any palliative care, far more likely to get it in the community. They get it an average of 3.5 months prior to death for the first time versus those dying of lung disease getting it only 3 weeks prior to death for the first time. And they get it more intensively. They get it more than 1 in 3 days versus somebody with organ failure getting it 1 in 4 days. And yet for all of that massive, like, you know, because palliative care is so tilted towards cancer care, if in any way provision of palliative care or unmet palliative needs was driving this, you just couldn't see 3 times the rate of MAiD in cancer than you see in non-cancer illness. Next slide. And you can just move on. It's the same point being made here. Opioid availability also, again, as a metric and again, as a surrogate, we don't know about availability, but I can tell you, we do know about opioid consumption. And again, just looking at countries that have legalized MAiD and countries where MAiD is available, are the countries with the highest consumption of opioids, right? So again, if opioid availability and opioid provision was a driving factor in this, you just wouldn't see this data. It's just not consistent with that. Next slide. I'm going to finish off with one more slide, just looking at, again, how effective we are at treating suffering. And I do want to make a clear distinction between eliminating or reducing suffering. I think palliative care is effective for reducing suffering. I do this for a living. I actually believe that my job has a value in the world. But the challenge is if we're trying to say that all we need to do is just involve more palliative care and the suffering will be addressed, I think we've got our work cut out for us. And again, I'm not just throwing out a couple of examples here, trying to look at some of the what we believe to be the high performers of the palliative care world. So on the left, we have home palliative care from Sydney, in the Sydney region. This is published data from David Currow. They compared, so they asked family members to rate the degree of comfort for patients in the final 2 weeks of their life at home. And the left column is those who got palliative care, and the right column is those who did not get palliative care at home. And while there is a statistical difference in comfort rates, so slightly more very comfortables and comfortables compared with very comfortables or uncomfortables in palliative care versus no palliative care, even among those who got palliative care, 47%, their family members rated their final 2 weeks of life to be either somewhat or very uncomfortable. That's concerning, right? Like we do benefit people, but that's not the same thing as saying we eliminate suffering, right? And I think that's important to be a little bit modest. And on the right, we have data from the MD Anderson Palliative Care Unit looking at symptom scores in the final week of life for patients admitted there. If there's a better palliative care unit in the world than the MD Anderson one, of course, it's at the Ottawa Hospital and Bruyere. But as a close second, we'll say MD Anderson. You'll see that actually the proportion of patients with ESAS scores greater than or equal to 4, so this is moderate to severe scores, and basically all of them are either high, increasing, or both in the final week of life. And this is under the care of a very most intensive palliative care you can provide. Patients have pretty high symptom burdens and they get worse. So this is not to say that palliative care is useless, quite the contrary. I would imagine if these people were not in a palliative care unit, they'd be doing substantially worse than this. But when you look at this, it's hard to sort of go from that to somebody who is tremendously suffering and say, don't worry, we've got you covered. I just don't think the data can support that. So those are the main points we wanted to make in terms of palliative care alongside MAiD. I think that's it. And I imagine we will have some discussion.
Yeah, and maybe I can just respond.
Oh yeah, sorry, Justin, go ahead.
That's okay. No, I just think there's something that I feel compelled to respond to in this last slide, which is that I think I've come to believe that often at the end of life we use the phrase something like, we're just going to keep you comfortable, and it's not exactly a euphemism necessarily, but it becomes to represent more than I think what it actually, or it's a simplistic construct. And actually within the history of palliative care, absent from the discussion well, let me just say that the relief of suffering is only part of, I think, what I think the sort of historical promise of palliative care is, which is about the potential for growth and healing in spite of serious illness and in spite of suffering, in fact. And in fact, and perhaps there's some who argue that healing is only possible in response to suffering in some way. So I think the elimination of suffering, in my mind, is potentially a simplistic construct that leads us to a place where if that's the only goal for the end of life, then in fact, it's true that perhaps medical assistance in dying makes much more sense, because it's certainly a more surefire way of reducing suffering. But I think that's where I think there's, again, we get back to this sort of fundamental tension. In places where palliative care becomes mostly directed around symptom management and this sole relief of suffering, I think it leaves our patients lacking, and in fact leaves us in a place where patients are likely not to find much more benefit with us than without us. So anyway, just to add that little tidbit at the end. But thanks for the opportunity to share this with James.